The physiological mandate of the thyroid gland is specific. Its primary function is to extract and consume iodine from the bloodstream. Nuclear imaging and therapeutic ablation are engineered to hijack this singular, iodine-consuming mechanism. This mandate presents a diagnostic trap. Measuring serum TSH, T3, and T4 in a standard endocrinology panel only reveals the hormone levels currently circulating in the blood. A lab profile showing low TSH and high T3 and T4 confirms thyrotoxicosis, but it cannot differentiate between a hyperactive gland manufacturing excess hormone and a dying gland passively spilling its stored reserves. To differentiate these states, we manipulate isotopic physics to exploit the biochemical gap between a cell pulling iodine inside and a cell permanently binding it. While serum labs identify the existence of an endocrine crisis, radiochemistry locates the source and determines the underlying mechanism. The thyroid cellular membrane serves as the foundation for scintigraphy, operating through two separate mechanisms. Trapping occurs when an iodine analog is pulled across the basolateral membrane into the cell via the sodium iodide symporter. Tc99m pertechnesate undergoes trapping exclusively. Because it cannot proceed further into the synthetic pathway, it eventually washes back out of the gland, resulting in higher background radiation and visible salivary uptake. Organification is the subsequent step, where the analog is oxidized by thyroid peroxidase and covalently bound to a tyrosyl moiety. Because iodine 123 and 131 undergo trapping and organification, they provide a map of actual hormone synthesis. This data matrix shows how the physical properties of these isotopes dictate their clinical application. Iodine 131 has an 8-day half-life and emits a 364 kiloelectron-volt beta particle. This high energy exceeds the depth of standard gamma camera crystals, resulting in poor image resolution. However, the destructive beta emission makes it a highly effective ablation tool, though it is strictly contraindicated in pediatrics and pregnancy. Iodine 123 decays via electron capture with a 13-hour half-life and a 159 kiloelectron-volt gamma emission. The 159 keV signature matches the optimal range for standard gamma cameras, yielding high-fidelity physiological images. Tc99m with a 140 keV profile is the pragmatic alternative, particularly useful when a patient's organification is temporarily blocked by recent intravenous contrast. Tracer selection requires precisely aligning the physics of an isotope's decay with the specific biochemical threshold required for the diagnosis. This diagnostic decision tree maps the potential causes of thyrotoxicosis when a patient presents with suppressed TSH and elevated T3 and T4. In Graves' disease, TSH receptor antibodies force the gland into continuous overproduction. The scan reveals a homogeneously hot, enlarged gland with radioactive iodine uptake often exceeding 50%. In toxic multinodular goiter, the overproduction is localized. The scan shows distinct hot nodules suppressing the surrounding tissue, with moderately elevated uptake levels. Granulomatous thyroiditis follows a different pattern. A viral prodrome causes cellular destruction and a sudden release of hormone. The resulting scan shows a nearly blank thyroid outline with an uptake percentage near 0. While the de Quervain's patient suffers from severe clinical symptoms, the nuclear scan is blank because the damaged thyrocytes have ceased active iodine trapping and organification. Treating de Quervain's patients with radioactive iodine based on serum labs alone is a clinical error. There is no functional tissue available to absorb the dose. The trapping and organification logic also applies to localized findings, specifically the discordant nodule rule. If a nodule appears hot on a technetium scan, but cold on an iodine 123 scan, the tissue has maintained the ability to trap via the symporter, but lost the ability to organify via thyroid peroxidase. This loss of organification is a hallmark of cellular dedifferentiation, making a discordant nodule highly suspicious for malignancy. High serum hormone levels paired with a blank scan prove the gland is undergoing cellular destruction rather than active overproduction. This graph illustrates the protocol for treating differentiated thyroid cancer following a thyroidectomy. Effective iodine 131 ablation requires maximizing the physiological drive for remaining cells to absorb iodine. Clinicians achieve this by allowing TSH to rise via hormone withdrawal or recombinant thyrogen. Once TSH exceeds the 30 to 50 threshold, the tissue is prepared for the dose. If diagnostic uptake exceeds 5% post-surgery, the residual tissue burden is too high for immediate ablation, as it risks causing painful radiation thyroiditis. A second rule of ablation involves the exclusion of medullary thyroid cancer. Medullary cancer originates from neuroendocrine C cells rather than thyrocytes. Consequently, it lacks both the sodium iodide symporter and the organification mechanism. Because medullary cancer will not trap iodine 131, radiotherapy must pivot to agents like octreotide or PET-CT imaging if calcitonin levels are elevated. Targeted radioablation works by leveraging the patient's own natural endocrine feedback loop to force the target cells to consume the radioactive isotope. The Wolff-Chaikoff effect represents a different manipulation of the iodine pathway. When the thyroid is exposed to a massive acute overload of stable iodine, the gland temporarily shuts down hormone synthesis. This shutdown lasts for several days before an escape phenomenon occurs, providing a window to treat life-threatening thyroid storm. This mechanism also explains why patients taking iodine-rich medications, such as amiodarone, may develop sudden hypothyroidism. Thyroid nuclear medicine is built on these predictable cellular mechanics of the iodine pathway. By precisely identifying the biological threshold between what a single cell traps and what that cell permanently organifies, physicians turn elemental affinity into a tool for diagnostic clarity and targeted eradication.